Good evening, ladies and gentlemen, and welcome to Dental XP. What I'm going to be sharing with you now is a short case that I've done with the ridge split technique with the immediate implant placement. And I think ridge split is very much a type of technique that's underutilized, and it's a very useful technique in our armamentarium, and something that I find that I use more and more these days for the specific reason that we end up in a lot of our cases where we just don't have enough bone. And to show you a case like this where we're dealing with just enough, but not enough that we've got the right amount of bone over the buccal of the implant. And if we look at Grunder and Spray's articles where we know that we require that 2 millimeters of buccal bone and palatal bone to make sure that we've got stable bone and stable soft tissue, more importantly, over the implant, then a lot of the cases that we do are just a little bit too little. And if you look at the case that we show here, you can actually see that, when we prep the site, although we've got bone now, and if we look at this next implant case, you can see, and this happens fairly often, where we've just got a 0.5 millimeter left of bone, and sometimes the bone cracks a little bit, and the prognosis of that bone is not good. In other words, in a lot of our cases, over time, that bone disappears. And if we've got a thin gingival morphotype, or if we have multiple teeth being extracted, what happens over time is that we start to see the shine through of the implant because it has no buccal bone. Now, although the implant is well integrated and happy, this is more a situation of soft tissue and stability. How often do we get cases like this when we look at the CT scans and we think to ourselves, we're just enough. And really what we're looking at, if we want to place a 4 millimeter implant in posterior, or 4.3 or 4.5, which is really some of our smaller diameter implants in load-bearing areas, a lot of the times we end up with situations like this where we're just dealing with 5.1, 6, 7 millimeters, and that's really not enough. Because if we look at the 2 millimeter rule from Spray and Grunder et al., then basically what we're looking at 4 or 4.5 plus another 4, which is around 8.5 millimeters worth of ridge. And if you think of how often you open up a ridge and find that you've got 8.5 millimeters, so that you can put your implant in the correct vertical and three-dimensional position, and on top of it have your 2 millimeters buccal and 2 millimeters lingual, it doesn't happen too often. And here you can see the type of case here where it looked nice, but as soon as you take a measurement, it's only 5.1 millimeters. So for me to go in there and put a 4 millimeter implant into the site, I need to expand this ridge by about 3 millimeters so that I can actually get it nice and thick. And here you can see the type of ridge in this case, here with a little bit of the ridge split and the pilot drill, and finally the placement of the implant. And you can see now, just with that little bit of ridge split in the area, with nice bone that's being packed out, we've really got a fantastic result with nice 2 millimeters of thick buccal plate. Now the question always comes was, well, I can always graft on the buccal. And I think where the ridge split technique is better than the buccal grafting is that the ridge split basically gives you a very well contained defect in which to pack your bone. So you've almost got a 3 or 4 walled pocket or bone defect in which to pack your bone. So you almost don't even need anything over that because it follows all the right criteria. It gives you good graft stability, it gives you good space maintenance, which is held open by the implant, and really just gives you enough time for the blood supply to go in there and to convert that bone, which makes it a very easy and very successful treatment technique. If we look at the short video that I'm going to show you now, this is the case that we're dealing with. And if you have a look closely, you can see that we only have around 5.7 millimeters in the defect area over here. And as a result of that, we don't really have enough to place a 4.5 millimeter implant. So what we're going to do here is, if you look with the implant in position, you see we're going to end up with a very, very minimal amount of bone over the implant. So as a result of that, this next case that we've got, we want to do a ridge split. As you can see, we've already done a very successful sinus lift. It tapers off around the back. We could have maybe prepped it up a little bit further at the back if I'm critical of my own work, which is always good to be. But I think with a good ridge split here from the 5.7 or 6 millimeters that we've got, we really should be able to get a nice thick ridge with good stable buccal bone that will then hold the soft tissue over the long term, rather than finding that in a year's time everything's resorbed and the soft tissue starting to recede. So let's go into the video now, and you can see the video is really, as I said, ridge split and immediate placement. This is a patient who wanted to have teeth in the back jaw. You can see the missing teeth, the last molars. And what we're doing here, we're doing a mid-crestal incision, which is very important because it gives us our best type of healing. And what we're going to do, which is very, very important with this technique, is a split thickness flap, which means that we are going to keep the periost against the bone, except in the occlusal surface. So as you can see, in the occlusal surface, we are raising a full thickness flap until we get to the edge of the bone as it starts to travel upwards. And from there, we will then start to do a split thickness flap so that we maintain the periost against the bone. The purpose of this is that it maintains the blood supply to the bony wall, so that should there be any green stick fractures or any breakdown, that we actually have a situation that it maintains its nourishment, and we don't get the type of resorption that one would normally get if we actually had nothing there. If it does split off, we'll do a little bit of a talk, and we've got a case where we show the split off and how we deal with it. But it generally can be dealt with almost like a bone block using screws. So here you can see in the video where we're doing a split thickness flap, being very, very careful not to perforate, and going as close to the bone as possible, and leaving that periosteum well against the bone. Here you can see once we've lifted a full thickness flap, we're trying in our stent. And I reiterate this extensively, a stent is absolutely important no matter how experienced you think you are. For every single case we have a stent. The next phase is using a piezo bone cutter, and that's our treatment of choice. And you can see the piezo slowly cutting bone. Some people might say it's very, very slow, but you know, we're not in a sprint race. You know, this is a marathon, and we want to do things right. We want to do things the right stage. So what we're going to do now is we're actually going to split the ridge to the complete depth. We're not going to just split the cortical bone, because if we just split the cortical bone, we will end up fracturing the top part off as we screw our implants down. So we slowly create a deeper and deeper cut. And if you remember the scans, it's probably around, it goes from around 8 in the posterior to around 10 in the anterior. So that's as far. We'll probably go to around 7 and 9. We don't have to go all the way through, just to give us enough depth to actually split the ridge nicely and to move the whole ridge out as well as possible. So there you can see getting to a nice 7-8 millimeters down. The cutting disc has markings on the side, which will give you an idea as to where the depth is going to go. So they're just slowly increasing the depth, making sure that everything's right. And again, now we take our pilot drills with our stent, making sure that we get our position correct. Everything is prosthetically driven, so it's important that you work from the top down. And from now, what we do is we take our pilot drills, our 2mm drills, our twist drills, and now we work to our depth with our 2mm twist drills. And that's pretty much the only drilling that we're going to do, because from here, what we now do is we now utilize our implants to expand the ridge further. You can obviously use ridge expanders, and here you can see us actually checking to see that the angulation that we've used, and you can see with confirmation with the x-rays that the position that we used is absolutely correct. So here we've gone up a little bit higher just so that we've got a little bit of space for our implants to grab. And 10 millimeters in the front and 8.5. We also feel now to make sure that there's no perforation. We're making sure that everything's set. And now we take our first implant and we place it. And when we place it with our handpiece, which is my preferred method of placement, we don't put the first one in all the way. We only put it in halfway and we let that sit. We then take the second implant and we place that in the back one. And we slowly place that one into position and also allow that to sit. And we now just let the body just absorb the energy that we've placed into it, and let that energy just dissipate. Let the bone take up the expansion that we've given. Now we go and we slowly do a little bit on the front, a little bit on the back, a little bit on the front, a little bit on the back, slowly expanding the ridge as we go along. By doing it this way, we tend not to cause too much pressure in the one area, and we expand the ridge altogether. So a little bit there, we go back to the front, and we place that a little bit deeper to the final position. And you can see by doing it this way, it slowly expands the ridge. And I think this is the critical thing about doing a ridge split, is that you actually slowly split the ridge rather than go in and try and finish this in an absolute sprint. Another important aspect of doing a ridge split is that you want to put the top of your implant at least 1 to 2 millimeters below the ridge, because we generally tend to get a little bit of resorption around the top. And to prevent exposure of the neck of the implant, we just sink it a little bit deeper, so that we make sure that if it does recede, then we still well, our shoulders are well in bone. Confirming our position of our implants through our stent, which is used extensively. Placement of our cover screws into position, so that everything's nice and sealed. And you can see the nice split open that we've created there of around 3 to 4 millimeters. We now take a little bit of PRF, and one of the PRF membranes that we're going to use, we're going to chop up, and we're going to utilize that for mixing with our xenograft. And that mixing with the xenograft will go into the defect that we've created with the split. And once that defect is created, once that defect is filled up with the xenograft and the PRF, it's going to give it a little bit better healing properties. There you can see it nicely chopped up. And now we just add the xenograft into position, and you can use xenograft or whatever. We add the PRF liquid as well, and we mix the two together to get a nice stew. So it's all very nicely mixed up, and try and mix it all so that you get a nice consistency of material in that area. And there, what we use is we just use a sterile insulin syringe. What we do is we just take it out of the sterile pack and we cut off the needle, and we just use it as a nice plug. It's a very nice way of placing everything. We use it for sockets, for sinuses, for everything. It's just a nice way of picking up our material and for administering it. And now what we do is we just pack that defect, and it doesn't really matter what you use here. You can use anything, because as I said before, we've got great space maintenance, we've got great graft stability, and as a result of the great space maintenance and graft stability, we should actually get good bone formation within the split, no matter what, because the two bone plates are holding the graft very, very firmly, and that then allows new blood supply to grow in, and for it to actually form beautiful bone in that area, which will then form a nice casing around the implants and provide us with that bone that's required for good primary soft tissue stability over the long term. So here again, we're just taking a perio probe. I find if we don't use a perio probe, what happens is that the bone quickly forms a bottleneck, and you don't pack it all the way down the fracture. So you want to actually use a perio probe. Then you go back to your small pluggers. It is also very important, this is not amalgam, and it doesn't need to be compacted. In fact, it's contraindicated to compact it. The more you compact this bone, the more you crush the actual morphology that makes this bone so good. The whole point of having the bone the way it is that it is osteoconductive, and that's because of the pore size and the little spaces that it has. And if you crush it, you will actually destroy that property. Here you can see what we're doing now is we're just placing PRF membranes over the top just to cover up the defect. And we've just folded the PRF membrane in half because it's quite large. So we actually, in all, you've got about 4 PRF levels going in here, which is great. And in this case, because we've got such a small defect, I'm not even going to use a membrane. Some of you might prefer to use a collagen membrane, and that's fine, not a problem at all. I don't find that it's necessary in all cases, and with a nice thick gingival morphotype like this one, I don't think it's necessary at all. And we get to suture. The suture that we use is a 6-0 nylon, which I prefer, or a 6-0 Prolene, which I prefer more than anything else. It is a monofilament, and the benefits of this is that it slides really, really well. And the benefits of a 6-0 is that you cannot really put too much tension on the tissue, and if you pull too hard, it tends to break the suture, which is great, because I'd rather break the suture than cause too much tension. If you can, as you can see here, the most important thing is that we are now suturing the corners together. I think it's a basic principle of any flap surgery, where you actually take one corner, suture the other corner together, and then from there you can then close everything in the middle, and then you do your releases. Here you can see the completion of the suturing with a continuous interlocking suture, keeping everything together. And we'll now open this case up in around 4 months, and you can see the final radiograph of the implants in position. And the distal one may be heading a little bit out of the bone there, but it'll still be good. We'll have great bone quality. And in around 4 months' time, we'll do an exposure, bringing some of the palatal tissue over from the buccal, so that we can make sure that we get a fantastic, thick, soft tissue, which is nicely firm and attached to the gingiva. I hope you enjoyed it, and with that, I say thank you very much. And thanks again to everybody for listening, and thanks to the Dental XP team for having me on Dental XP. And I look forward to seeing you soon.